which I think is really important for the fellows, because certainly from the nursery, this is the most common reason why we get a GI consult. It's to deal with issues of bilirubin, either production, bilirubin elimination, unconjugated, conjugated. So we'll go over specifically the problems of cholestasis and the diseases associated with it. So our learning objectives will be to learn bilirubin production, metabolism, transport, and genetics, to know the various causes of jaundice and be able to formulate a differential diagnosis, understand liver anatomy and physiology in terms of its metabolic profile, the way products are excreted into the biliary system, and what products are synthesized. And then we will, of course, review cholestatic disorders, reviewing the causes of neonatal cholestasis, identifying and diagnosing cholestasis. And for the first part of this two-part lecture, we will concentrate on biliary atresia. And the second part, we will be concentrating on other genetic causes of cholestasis. So we can call the liver the master integrator of metabolism and inflammation. It has thousands of functions. It integrates all elements in the diet, fat, cholesterol, protein, nitrogenous compounds, amino acids, and carbohydrates. It's the source of most serum proteins, but not all, albumin and complement, and the liver-specific clotting factors, which you should all be familiar with. It's a storage organ, so it stores the fat-soluble vitamins, all of them, as well as vitamin B12, and it also is a storage site for minerals. Iron and copper being the outstanding examples. Of course, we will deal specifically with problems of heavy metal storage later in the semester, or year, if you will. And it produces bile. Now, bile, it's produced up to 1 liter a day, which is obviously essential for digestion, the formation of mixed micelles we went through in a previous lecture, and is also responsible for the elimination of bilirubin. And last but certainly not least, the liver is responsible for the metabolism and excretion of drugs and toxins, most prominently via the cytochrome P450 system. It also is the recipient and eliminator of bacterial products that are that undergo absorption in the gut. The normal vascular anatomy of the liver is shown here. Approximately 50% of the blood coming into the liver is the portal vein, and the portal vein is shown here, pretty much in the center of the slide, as the confluence of the superior and inferior mesenteric veins, and then as well as the splenic vein, and then the hepatic artery supplies the other 50% of the blood flow to the liver. And so these are the basics of the biliary tract shown here, with the liver and the stomach in the background. We have the biliary tree with the left and right hepatic ducts, the common bile duct, the gallbladder, and then, of course, all empties into the first part of the duodenum at the level of the ampulla of Vater. There is an overall paradigm that we can use when discussing hepatic metabolism and detoxification. Of course, the first is the import phase, where blood through the portal area will deliver a variety of drugs and toxins that are picked up by the hepatocyte. During phase 1, these compounds undergo hydroxylation, again, via the cytochrome P450 system, predominantly in the smooth endoplasmic reticulum. Phase 2, most of these products will undergo conjugation. Conjugation, making them a salt, if you will, It can be sulfated, glucuronidated, glutathionated, and this can take place either in the smooth endoplasmic reticulum or in the cytosol. And conjugation here of bilirubin is via UGT1A1, as you're all familiar with. And then finally, there's the export phase where these conjugated compounds, toxins, drugs are going to be eliminated into the biliary canaliculi. And for some of these products, if they're needed somewhere in the body for circulation, predominantly, they can go backflow back into the sinusoid. That's the export phase. Of course, this can also happen in disease states where these compounds build up to an excessive degree and then spill back into the sinusoid. You should all be familiar with the three major histologic zones in the liver, zones 1, 2, and 3. Can anybody tell me the difference between these zones? Well, the major difference is, of course, the level of oxygenation. As you go from zone 1 to zone 3, oxygen tensions decrease. As to finally the blood, having given up its oxygen, if you will, is then flowing into the central vein. There's zone 1, zone 2, and zone 3. In zone 1, we have the processes of fatty acid beta oxidation. It requires oxygenation, cholesterol synthesis, and gluconeogenesis. So a lot of your synthetic pathways take place here in zone 1. In zone 3 is where drug metabolism, ketogenesis takes place. This is where bile acids are synthesized, and this is where glycolysis takes place. And zone 2 is sort of a zone that's an intermediary between zones 1 and 3, where we have a transition of these two distinct metabolic functions, group of metabolic functions. Bilirubin, of course, derives largely from red blood cells, also from the muscle and in the liver. As red blood cells become old and damaged, they get broken down, releasing in largely hemoglobin and finally heme, and then heme is further broken down, and unconjugated bilirubin is produced. Most of this takes place in the spleen. There are distinct mechanisms for bilirubin and bile acid transport. So this is why we talk about bile acid dependent and bile acid independent flow. Bilirubin and bile acid transport are two unique processes. Bile acids enter the blood largely coupled to sodium via sodium taurocholate transport and enter the hepatocyte. And then we have organic anions via organic ion transport proteins will also enter the hepatocyte. UDP glucuronal transferase then is responsible for the production and excretion of bilirubin and other conjugates into the biliary canaliculus. So here we have bile acids transported in the liver, and then bile acids independently or independent mechanisms are excreted into the bile. Albumin picks up organic ions. It also picks up unconjugated bilirubin, and that's transported into the hepatocyte. So what happens in terms of bilirubin transport and bile acid transport, and we'll go over this in much greater detail later in this series of lectures, but one of the key transporting proteins up at the top is the bile salt export protein. Bile salt export protein mutations are associated with progressive familial intrahepatic cholestasis type 2, and we'll talk about that later. And then bilirubin is very interesting in terms of the problems associated with it. We have various levels of functioning of UGT1A1. We can have something called a problem in the promoter region of UGT1A1, and that's associated with mutations in that gene is associated with Gilbert disease. And then we have either the complete absence of UGT1A1, or that would be Crigler-Najjar type 1, and then Crigler-Najjar type 2 is the so-called phenobarbital sensitive that phenobarbital can upregulate UGT1A1 in those patients. And again, we'll be discussing all of these in greater detail. This then sort of is an overview of what I presented in the previous slide regarding the disorders of bilirubin transport and metabolism. We can have an uptake defect, or we can have a problem where we have perhaps a delayed uptake that's associated, it's thought to be associated with Rotor syndrome, which is a delayed uptake, and a problem in the level of functioning of the organic anion transport protein. Here up at the top, you see problems with UGT1A1 leading to a Gilbert and Crigler-Najjar. You may never see a Crigler-Najjar patient, but I guarantee you, you should have already seen plenty of Gilbert patients, because that disease occurs in 7% of the population.
We have a possible Crigler-Najjar we just saw in clinic yesterday.
Really? Must have been type 2?
Type 2, yeah. If it is that. If it's either going to be breast milk jaundice late or a type 2 Crigler-Najjar. So it's an indirect Bili of 7, direct is 0.22, no liver injury, kids otherwise doing great. So I am thinking it's one of those two things, because it's a little too high for Gilbert.
Did you say an indirect of 7 and a total of 22?
0.22. Total of direct of 0.22. Total was 7.22.
And a direct of 0.2.
Yeah.
Oh, okay. All
yeah,
right.
sorry, I was speaking.
Because if you said a direct of 22, I'd have said you got to be
no,
very
a direct
careful.
of 22 would be bad. I'd be doing a much different set of things.
Yeah, all right.
But no, in this case, it was all indirect. But you know, it definitely wasn't high. It was a little too high for Gilbert's, though possible for a 3-month-old. So my differential is Crigler-Najjar 2, breast milk with a late presentation, or late continuance, and then or Gilbert's. That's just notable.
Well, Gilbert typically raises its head in adolescence. That's when we see most of the patients. And it is a problem in the promoter of UGT1A1. It's a totally benign condition, or thought to be a totally benign condition. Dubin-Johnson gives you the so-called black liver. This is a problem of conjugated bilirubin excretion. Again, it is not associated with any overall deleterious effects on the subject who has that disorder. So breast milk jaundice, you walked right into it. How long is too long? Well, here's one of the first studies, if not the first studies of breast milk jaundice, 1978, if you can believe that. Almost 900 infants from the UK, 55% were breastfed, and 12 were jaundiced for longer than 3 weeks. That's 2%. And this is a very worthwhile slide for the fellows to look at, because, of course, we know that unconjugated bilirubin is very common in the newborn. It's a result of sort of the delayed development of the mechanism of bilirubin uptake and conjugation. It also is associated with breast milk. The exact reason why babies who are breastfed are jaundiced is not fully understood, although there are a number of theories. And typically, the height of breast milk jaundice, as shown on this graph, is at about 2 weeks of age. All right. For those patients, and this is I'm going to show you some data which really contradicts that, who develop biliary atresia, if you will, they start to develop conjugated bilirubin around conjugated hyperbilirubinemia at about 2 weeks of age. So that by 3 weeks of age, we're going to use the midpoint, the increase of conjugated bilirubin begins to rise, and we have a fall off in unconjugated hyperbilirubinemia. So in the old days, we used to say if at 2 weeks of age, an infant is hyperbilirubinemic, one must get a fractionated bilirubin because this is when you are going to start to see evidence of conjugated hyperbilirubinemia in those infants who perhaps are going to ultimately be found to have biliary atresia. But the data has changed since that point, and we'll talk about it a little bit later. So again, I want to go back to Gilbert syndrome. It's very common, 5 to 10% of the population, often with a family history. Gilbert is associated with mild episodic hyperbilirubinemia, all indirect. 1 to 5 milligrams per deciliter is typical, although I've seen it up to 9 milligrams per deciliter. It's generally found incidentally on routine blood work. Typically presents during adolescence. It's not thought to have any clinical importance, but tends to be uncovered during a time of an acute viral illness. If it's not found incidentally, it's found at a time of acute viral illness where all of a sudden the patient or their parent says the child is jaundiced. The genetic etiology here is a mutation in the promoter of UGT1A1. So, as fellows or as attendings, if you're presented with a consultation of a child who has an elevated bilirubin level, what do you try to do? Well, the first thing you try to do is find out if it's liver in origin. What's the simplest way of finding out if it's hepatic in origin? Well, initially, is it conjugated or is it unconjugated? It doesn't tell you, that will tell you if it's cholestatic or not, but it won't necessarily tell you where the origin of the problem is. So let's look at the history. Is there a history of hemolysis or cardiac disease? Is there a history of a recent illness or medication? Does the patient have pale stools? Okay. In older patients, obviously, is there evidence of pruritus, right upper quadrant pain, dark urine, hematemesis, which would be late in the stage of portal hypertension? That's why I grade those areas out. What about the lab work? What is the difference between direct and indirect hyperbilirubinemia? Simply put, direct hyperbilirubinemia can be defined as a direct reacting bilirubin level greater than 1 milligram per deciliter or greater than 20% of the total bilirubin for a total bilirubin of greater than 5 milligrams per deciliter. Learn it, remember it, because that is the most important test that you're going to do when you're going to try to differentiate direct from indirect hyperbilirubinemia. Once you get that level, then there are other blood tests that you want to look at. Is the gamma-glutamyl transferase elevated? Is the ALT-AST elevated? Is there an elevated INR, an elevated serum ammonia? This is further down the line, but your first laboratory test is to define whether it's direct or indirect hyperbilirubinemia, or a mixture of the two. What about the examination? Evidence of hepatomegaly, evidence of portal hypertension, pale stools, which indicate potentially a problem in biliary excretion. And then finally, we have the imaging studies that we can do before we get invasive about things. Is there evidence of a dilated common bile duct, stones, or sludge in the gallbladder? Any masses present? Anything suggesting a cystic structure or an abscess formation? And again, is there splenomegaly or abnormalities in splenic structure, either polysplenia or asplenia? Again, those are important considerations when making a diagnosis, particularly of biliary atresia. So once we decide that this is cholestatic, in order to do that, we have to understand what cholestasis is. Cholestasis is a syndrome resulting from impaired delivery of bile to the duodenum from any cause, and is characterized by specific changes in biochemical markers in the plasma. Cholestatic liver disorders include a spectrum of diseases of diverse etiologies that are characterized by impaired hepatocellular secretion of bile and the accumulation of everything that's in the bile, bile acids, bilirubin, and cholesterol, or other toxins or metabolic products that are excreted in the bile. In the neonate, the major causes of cholestasis can be summarized here: biliary atresia, the genetic causes of cholestasis, the PFICs, the Alagille syndrome, and the specific cholangiopathies, adult recessive polycystic kidney disease, cystic fibrosis, all of which are associated with specific cholangiopathies. And as part of this series of lectures, we are going to evaluate recent guidelines from the AASLD on how these disorders should be managed, diagnosed and managed. First and foremost, cholestasis involves impaired bile flow. You can see on the left evidence of intrahepatic cholestasis marked by the brown pigment that you see throughout these hepatocytes. This is bile accumulating in the hepatocyte. This can lead because these bile products can be toxic, and they lead to cell death, and cell death ultimately leads to inflammation and fibrosis leads to cirrhosis. What happens in the intestine? Well, if you don't have adequate bile flow and you don't reach that magic number of 4 millimolar of bile salt concentration, which is the critical micellar concentration, you can develop fat and fat-soluble vitamin malabsorption. So patients may develop diarrhea, ultimately have nutritional compromise. Reduced vitamin absorption results in deficiencies in the fat-soluble vitamins. The key to all of this and prevention of all of this is the maintenance of the enterohepatic circulation of bile acids. Cholesterol is the mother product, the mother starter for all bile acids, and the synthesis of bile acids goes through steps involving 14 different enzymes for cholesterol to ultimately become a bile acid. The enterohepatic circulation is extremely efficient, so 95% of the bile salts that are excreted into the intestine will be reabsorbed in the terminal ileum. There are specific bile acid transporters both in the liver and the intestine, and each bile acid circulates 8 to 10 times per day. Virtually all of this enterohepatic circulation occurs in the hours following a meal. Bacteria in the lumen can modify bile acids as well. The maintenance of bile acid flux is clearly relevant because the synthesis of bile acid depends on feedback regulation, so that of the 5% of bile salts that are lost in the stool every day, that has to be resynthesized. Bile acid flux is important to maintain bile flow, for the absorption of fats and fat-soluble vitamins, and for overall hepatic metabolism. If we look at the causes of neonatal cholestasis, this slide was published in 2014. It's fairly relevant as well today. Clearly, when we have a problem of direct hypobilirubinemia indicating cholestasis in the newborn, first and foremost, we worry about biliary atresia because of, in this study, and it's been confirmed in other studies, biliary atresia likely represents at least 40% of the patients, of newborns who exhibit cholestatic jaundice. And then you see the other causes, PFIC, just preterm birth and immature metabolism. The idiopathic cases are getting smaller and smaller as we learn more about the genetic causes of cholestasis. And then we have a whole other laundry list of disorders, some of which we will be talking about, particularly Alagille syndrome, alpha-1 antitrypsin deficiency. We will concentrate on those in the second part of this lecture. And the PFICs are shown here. I highlight them here because they're favorite board questions for the fellows. Again, the indeterminate cases are less and less each year. So when we think about cholestasis, we have to think about where in the whole spectrum of bile acid synthesis, conjugation, and excretion the problem resides. Is it hepatocellular? Is it a problem of the enterohepatic bile ducts? Or is it a problem of the extrahepatic bile ducts in the gallbladder? Well, of course, we know when we're talking about biliary atresia, the problem is extrahepatic. When we talk about Alagille syndrome or alpha-1 antitrypsin deficiency, the problem tends to be intrahepatic in terms of intrahepatic bile ducts. And hepatocellular causes, we've already talked about, but those deal primarily with the PFIC syndromes and other problems where we have direct problems of excretion of bile and bile products into the biliary canaliculus. So, just to review, again, we have neonatal cholestasis, and now thinking anatomically, we have the extrahepatic bile duct, the intrahepatic bile duct, and the hepatocyte. Biliary atresia, number one. Then in the intrahepatic bile duct, the problems of bile duct paucity. Unique among these disorders is Alagille syndrome. And then we have the rare, much rarer ductal plate malformations. Now, I'm not going to go over all of these. These are things you should read about and at least have a passing familiarity. The ones I have highlighted are ones you clearly need to know about in greater detail in terms of, is it genetic? If it's genetic, where's the mutation? And how is it manifest? So in the hepatocellular causes, as I mentioned, those include the neonatal hepatitis syndromes, a wide variety of viruses shown here, but importantly, problems of progressive familial intrahepatic cholestasis, which are highlighted in red, as well as the problems of bile acid synthesis and alpha-1 antitrypsin deficiency. Down on the list, on the lower left, we have the miscellaneous cause, and you will be getting a separate lecture just on TPN-associated cholestasis. Again, because of its relatively common nature in tertiary care units. Biliary atresia. This happens to be a liver from a patient who underwent, obviously, a liver transplant. And as you can see, it's green and nodular. This is a cirrhotic liver that had to be transplanted. Biliary atresia is a fibro-obliterative cholangiopathy with obstruction of the common bile duct as a central component. There are no clear genetics, and that, for example, monozygotic twins are usually discordant, so that something else is going on that's not really genetic. In 5 to 10% of patients with biliary atresia, they will have problems with laterality, situs inversus, situs indeterminus. They may have asplenia or polysplenia or cardiac defects. This 5 to 10% represents those patients with the so-called fetal form of biliary atresia. These are the patients who present within the first 2 days of life, as opposed to the classical form of biliary atresia that typically presents at a couple of weeks of life. And when we look at a biopsy shown to the right here, one of the outstanding features, aside from biliary ductular proliferation that they're all familiar with, is the problem of extrahepatic bile duct plugs, extrahepatic cholestasis. The worldwide incidence of biliary atresia is shown here. It is much more common in Asia, particularly in Japan. The incidence is 1 in 5,000 live births. That compares to the incidence in Europe and the United States, which is anywhere from 1/2 to 1/4 as frequent. And let's compare that to cystic fibrosis, where we see the reverse. In Japan, CF is very rare, but it is much more common in the US and in the European Union. So the natural progression of biliary atresia histopathologically is shown here. Here we have a biopsy from a 3-month-old, where the main feature is biliary ductular proliferation. And you can see now, for the fellows, the way I show it, and I'll show you on other slides, is that the bile duct, I call it a string of pearls. It's a very round nucleus in a square cell. So if you look at it, and I'll show you other slides that are better, here's one that looks good. It's a string of pearls sign. That's what the bile duct looks like. Now, here, we have an empty bile duct. Let me see if there's one that's packed with bile here. Here, this one has bile sticking in it. Here's a very good one. This is the biliary ductule, and you can see the bile in it. Here's another one. Okay. And these are the so-called bile duct plugs. And ultimately, untreated, this winds up like this. This is a trichrome stain, and you can see the blue, which represents fibrotic tissue. This is already cirrhotic. As I mentioned earlier, the features of biliary atresia can be divided into 2 major forms. The fetal or embryonic form, I think that 20% is a bit high, but it doesn't really make any difference, or the peri or postnatal form. In the fetal or embryonic form, these tend to be AGA or SGA infants. They're characterized not only by biliary atresia, but by other anomalies: polysplenia, asplenia, cardiac disease, problems with situs inversus or situs indeterminus, malrotation. They may have a preduodenal or an absent portal vein, an annular pancreas, or an duodenal or jejunal atresia. For the fellows, this is important to note because one or all of these abnormalities may appear on the boards, and you'll be asked to come up with the hepatic diagnosis. So remember this. These patients tend to have complete acolic stools from birth, and they have no jaundice-free interval. So it's not like they have early unconjugated hyperbilirubinemia, then that goes away, and then jaundice reappears. No, they're jaundice from day one. In the more common peri or postnatal form, these are full-term AGA infants with no extrahepatic anomalies, intermittent acolic stools, and they generally have a late rise in direct bilirubin. However, do they really? This is a study that was published in Pediatrics in 2011, looking at patients with biliary atresia, finding that they actually did have elevated direct levels of bilirubin shortly after birth. So here we have the bilirubin level within 24 to 48 hours of life in children they have early cholestasis, and This was found to be a cardinal feature of biliary atresia. And here we have a good slide looking at it. 0 to 24 hours, direct bilirubin 1.5 at 48 hours, 2 at 48 to 72 hours, and 2.5 at 72 to 96 hours. What does this tell us? Well, this tells us that there's an opportunity for newborn screening. And I would suggest, given our patient population, given the fact that follow-up is not always easy, and I'd like Dr. Levine, Dr. Rabinowitz, and Dr. Wallach to comment on this. My personal belief is that all babies who are jaundiced at the time they leave the nursery, otherwise normal delivery, should have a fractionated bilirubin.
I think that's not unreasonable, and I also wish we gave out the stool cards that they give out in Japan.
Simon, what do you think?
We get a lot of late missed biliary atresia because, especially in our population, it can be harder to detect jaundice.
Yeah, I think this should be standard practice. You know, the day of discharge.
I think that's reasonable, and the Bili cards are available online. And
Yeah,
because they're available online doesn't mean people know to look for them. It should be physically handed to people when they are discharged.
Yeah, but I think in those situations also that plus the fractionated bilirubin at discharge, I think, and we would have much better follow-up.
I mean, the fellow could simply print up and then give them out.
So, all right, Dr. Levine, and you had it hit the nail on the head. The biggest problem we have is reasons for late referral. This is extraordinarily important. When Dr. Rabinowitz and I were in training, we thought that we had to diagnose these patients by 8 to 10 weeks of age. Now it's clearly been shown that the earlier the diagnosis is made, the greater the chance that we can have a successful portoenterostomy, and the patient will survive with their native liver long term. The reasons for late referral are lack of follow-up of neonatal jaundice, which again, I think can be partially avoided. That problem can be avoided by the early diagnosis of direct hyperbilirubinemia. A misdiagnosis of breast milk jaundice. Baby comes in at 3 weeks of age, it's breastfed, looks jaundiced, but otherwise is vigorous. The pediatrician says that's just the breast milk. And we showed the slide of when breast milk jaundice should get better. The stools may be partially pigmented. And so keep in mind that when we give the stool cards out, any variance from a well-pigmented stool should be brought to the attention of the pediatrician, because these patients may have intermittently acholic stools. A well-growing baby. Babies with a postnatal form of biliary atresia are typically growing well until they're not. And then someone's just measuring the total serum bilirubin. So can any of the fellows tell me what the typical total bilirubin level is in a baby with biliary atresia? Total bilirubin. Well, it's rarely above 10. Most babies with biliary atresia will have an 8 to 9, and 50% of that will be direct hyperbilirubinemia. That's in contrast to some of the other cholestatic disorders where you get bilirubins in the teens or even higher. In biliary, it sounds intuitively that it doesn't make any sense, but that's the way it is. The typical total bilirubin level in these babies is 8 to 9, with about 50% being conjugated. In terms of those babies who don't have the associated anomalies, there are no physical findings that are pathognomonic for the disorder. The infants are typically full term, and may manifest normal growth and weight gain. Hepatomegaly may be present early, and the liver may be firm or hard to palpation. You hope it's not, because that clearly suggests that we're already having cirrhosis. Splenomegaly is a problem because it suggests progressive cirrhosis with portal hypertension. Direct hypobilirubinemia, again, is the hallmark. Remember again that physiologic unconjugated hyperbilirubinemia rarely persists beyond 2 weeks of age. And again, if one's looking for anomalies, obviously one wants to make sure that there is no cardiac defect. The first line workup is to review stool color, get a family history, a birth history, check the newborn screen, get your liver studies. This is all standard stuff before the diagnosis. We typically get an alpha-1 antitrypsin level. One does not have to do pie typing if that level is normal. Again, a common cause of cholestasis in the newborn is a urinary tract infection, so we want to check that. Again, we want to make sure that there's no intervening viral infection that may be complicating the situation. Again, direct bilirubin is greater than 1, not 2, greater than 1 milligram per deciliter, or 20% of the total bilirubin level. Again, as I mentioned, the total bilirubin is typically not very elevated, 6 to 12. Again, most of the patients that I've seen have been in the 8 to 9 range. No single test discriminates between biliary atresia and other causes of neonatal cholestasis. However, at the risk of making the leadership of NASPGHAN unhappy, I will tell you that in my experience, I have never seen a baby with biliary atresia who didn't have an elevated GGT. Can any of the attendings argue with me on that point?
I don't think I can.
So to me, that's the most important test.
I cannot.
So get that GGT. If the GGT is normal, you're probably okay, certainly in terms of biliary atresia. Again, the serum alpha-1 antitrypsin with pie typing, again, if the level is normal, pie typing is not going to be necessary. Second line workup, again, we're looking at urine organic acid, succinylacetone. What do we get succinylacetone for? What disorder? Tyrosinemia, guys. This is stuff you got to know, all right? Growth, hormone levels, slit lamp examination, retinal examination. Well, again, I'm not sure we're going to do slit lamps on newborns. And then do we want to get an acylcarnitine profile? Do we want to measure serum bile acids? Again, these second line workups are when you've ruled out biliary atresia, pretty much. And then you start on saying, what are the metabolic or other causes of cholestasis? This is the surgical biliary remnant, a photograph of a surgical specimen of obliterated extrahepatic bile ducts showing fibrosis of the biliary ductal remnant. That's the black triangles. And a atretic gallbladder. Here's the gallbladder. It's atretic, and a fibrous common bile duct. All right. The fibrous ductal remnant shown here. Can anybody tell me what this shape is? Come on, guys. It's plain geometry. It's a triangle. This is called the triangular cord sign. And this is how an experienced radiologist, ultrasonographer, is going to give you a diagnosis of biliary atresia. So this schematic drawing represents the anatomic relationship between the fibrous ductal remnant and blood vessels around the porta hepatis. The triangular cone-shaped remnant is positioned anterior and slightly superior to the portal vein and the hepatic artery. all right? This is your triangular cord, and it's shown here. This is the triangular cord sign, all right? And this is a very, very, very reliable indicator of the obliteration of the biliary ductular system. The triangular cord sign in a proper ultrasonographer's, experienced ultrasonographer's hands is diagnostic. Another way to look at it is to look at a series of infants with conjugated hyperbilirubinemia and see if the gallbladder is detected or the gallbladder is not seen. If the gallbladder is not seen, there were 9 patients in whom the gallbladder was not seen. 4 had a triangular cord sign. Of those who had a triangular cord sign, all of them had biliary atresia. Where the triangular cord sign was absent, 4 out of 5 had no common bile duct seen. Of those, 3 had biliary atresia. So when the gallbladder was not seen and the triangular cord sign was absent, we still had 60% who ended up with biliary atresia. If the gallbladder is detected and it's normal, all of those patients had a triangular cord that was absent. Of those, only 4 had no common bile duct. And of those, only 1 had biliary atresia. So in 56 patients who had a normal shape and wall of the gallbladder, only 1 had biliary atresia. If the gallbladder was abnormal, that's 25 out of 81, 18 of those had a triangular cord, all of those had biliary atresia. Of those where the triangular cord sign was absent, 1 had biliary atresia. So, put it in a nutshell, if the gallbladder is seen and it's normal, you're unlikely to have biliary atresia. If the triangular cord sign is absent, then it's almost never see biliary atresia, although very, very rarely. So this gives you an idea. Look at the common bile duct, look at the gallbladder. If the common bile duct looks normal and the gallbladder looks normal, you're probably okay. This is a test I never do for biliary atresia. It's very sensitive, but not very specific. I tend not to do hepatobiliary scintigraphy. I think it leads you down the wrong path. The only way that hepatobiliary scintigraphy is going to be useful is if there's unequivocal excretion of dye into the intestine. And then ultimately, it goes into the kidneys as well. What we typically do for the diagnosis is a biopsy. And we're looking for bile duct proliferation with bile plugs and evidence of cholangitis. And we see ductular proliferation at the interface of the expanded tracts with bile plugs. Usually it's a mixed inflammatory infiltrate. There's usually portal edema and fibrosis, again, with a mixed infiltrate. Bile ductular proliferation is the key finding here. The biopsy has a 1-day turnaround. It's 76% specific and 100% sensitive for the diagnosis of biliary atresia. So all patients with biliary atresia are going to have bile duct proliferation, but not all bile duct proliferation is going to be biliary atresia. And here's a better. Remember I talked to you about a string of pearls? Here, here. Look at this. It's another one. String of pearls, string of pearls, string of pearls. All right? String of pearls. This is it's very easy, very, very easy to spot a bile duct histologically. And you should all be experienced in looking at this. You are going to get a slide like this on the boards. I guarantee it. This is a string of pearls caught in a different cut. So this is actually caught longitudinally. Here's an even better shot. String of pearls, string of pearls. And when you get this on the boards, it's not going to be subtle. They'll show you something like this, which is really obvious. So if we look at all of these studies in terms of their sensitivity or specificity, the sensitivity of ultrasound is up to 100% with a triangular cord sign, and the specificity is 98 to 100% with a triangular cord sign. It's up to 100% with a smaller absent gallbladder, both for sensitivity and specificity. So ultrasound, again, with an experienced ultrasonographer, is extraordinarily reliable. GGT, as we mentioned, again, I've never seen a baby who did not have an elevated GGT who had biliary atresia. Liver biopsy, again. Here's the problem with biliary scintigraphy. While it's very sensitive, its specificity is lousy. And so, again, I do not tend to use it in the diagnosis of biliary atresia. I never did. Don't do it anymore, but I never did. Here are the anatomic variants. Remember that biliary atresia does not present like this. It can present with only partial atresia. So let me see if any of the fellows can answer this question. Here's a patient with biliary atresia, has an atretic common bile duct, atretic cystic duct, and an atretic gallbladder. But the right and left hepatic ducts are normal. Why don't we just take these and anastomose those to the intestine? Or in this case, this is even better. We just have here a distal atresia, all right? Everything here seems to be relatively intact. Do you know why we don't do that? Well, no one wants to answer, so I'll answer for you, because they'll all wind up like this. I have been involved, I believe Dr. Rabinowitz and I were involved in the same case, I think, where a surgeon found that part of the biliary system appeared intact, and so anastomosed the intact portion did a Roux-en-Y to the jejunum. And eventually what happened, of course, is that this remnant ended up becoming atretic as well.
So we are short on fellows today because Bryce is out on bereavement leave and Shah's at NYU, hopefully also learning about liver. But does it make sense, Miriam, why that would continue to happen? If you're answering, you are muted. Oh, yeah.
Yeah.
What I think is really... Oh, sorry, go ahead.
Yeah, I'll try to do it next time.
Do what?
The answer?
No, don't worry. Yeah, but if you don't know that, I do want you to try, and it's totally okay to be wrong, especially for you, because you're your first year. The reason why you want to just keep in mind, just to reemphasize this, I think people very outside of PGI and hepatology very frequently think that biliary atresia is some sort of inborn issue. It is an active attack on your ducts. So even if you look good now, you're not going to look good later. The solution is basically go around the ducts or replace the liver. Those are the two options.
Part of the reason is that there's been a lot of work looking at reovirus type 3, looking at CMV, particularly antibodies in the mother of babies who had developed biliary atresia. So there is still thought that this may be, at least in some way, infectious in terms of its etiology.
Well, there's some evidence that during the pandemic, when viral infections collapsed, that biliary atresia rates dropped.
Yeah. So obviously, if you have an ongoing viral infection, this is not going to stop unless it can be specifically treated. So again, the process continues. The procedure is the Roux-en-Y, the so-called Kasai-Porter enterostomy, shown here. The prognosis following Porter enterostomy, this is my dear friend Frank Sinatra, This is his article. Again, it's an old one from 2001. And remember, I said we used to think of these infants doing well if we operated on them before 8 to 10 weeks. We don't do that anymore. But here is surgery less than 60 days. Again, if you look at this, really 2/3 to 3/4 ultimately go on to develop end-stage liver disease and require transplantation. That number really hasn't changed over the years. What has changed is how long a patient can survive with the native liver before they ultimately require transplantation. The prognostic factors are age at operation, the presence of bridging fibrosis, the bile ductular size, and the portal plate. So what the surgeon is going to do is they're going to dissect back to the porta hepatis. And one way of looking at it is if the biliary ductular remnant is less than 50 microns in diameter, that suggests that the Kasai is not going to work. If it's greater than 100 to 150 microns in diameter, there's a good likelihood that there's going to be a successful bile flow. Of course, one of the problems later on is the development of ascending cholangitis. We do have the biliary ductular, the porta hepatis, which is now anastomosed to the intestine. Perhaps the most important prognostic factor is the total bilirubin at 3 months. If it's less than 2 milligrams per deciliter, that indicates a much better prognosis. If jaundice persists, that suggests that the liver failure is going to be on its way. And then for those patients who have multiple congenital anomalies, obviously, the prognosis is worse. Serum transaminases and bilirubin level have no predictive value on the outcome. However, the rapidity to which bilirubin returns to normal after Kasai is an important predictor. And again, serum less than 1 to 2, serum bilirubin less than 1 to 2 within 3 months implicates a good long-term outcome. The complications after portoenterostomy is primary failure. Again, this is related to the size of the ductal remnant. The presence of bacterial cholangitis, which can occur in up to 60% of patients. Persistence of fever, hypopigmented stools, positive blood culture, anything that might suggest an infectious complication is going to be problematic and will lead to a failure of the portoenterostomy. In patients who have cirrhosis and portal hypertension, at the time of Kasai procedure, 20 to 60% will develop variceal hemorrhage. They also may develop other signs of hypersplenism and portosystemic encephalopathy. Pruritus still is a major problem, particularly in in Kasai failure. It can be treated by a number of agents, and the new agents are meropenem, the bile acid uptake inhibitors, which we'll talk about in a later lecture. In the old days, we used to use ursodeoxycholic acid, antihistamines, and topical agents. So now we're into really the ileal bile acid blockers as being more effective for a variety of cholestatic disorders, among them Alagille and alpha-1 antitrypsin deficiency. What about postoperative management? There's no evidence that antibiotic prophylaxis works. There's no evidence that ursodeoxycholic acid works. Obviously, we give all patients fat-soluble vitamins because of the problem with bile acid kinetics. Again, we'll generally recommend a formula that contains some amount of medium chain triglycerides. Again, it depends on the level of if cholestasis persists or not. One of the great controversies was the use of corticosteroids. Studies more recently looked at pulse high dose therapy of 10 milligrams per kilogram of prednisolone half a milligram per kilogram over 5 days, followed by half a milligram per kilogram over 5 days. That's the pulse of 10 per kilo, followed by 0.5 milligrams per kilogram. The conclusion was the rationale was that it was an IL-8 and monocyte chemoattractant protein inhibitor, so could prevent the further development of inflammation and fibrosis and would prevent post-op cholangitis. Those patients who received pulse steroids did worse. So we're not using that anymore. The long-term survival for biliary atresia has improved. Each of these Kaplan-Meier plots, if you go from bottom to top, look at the proportion of patients surviving, with between 1951 and 1998, you see how much better the curves get, indicating a better survival rate, largely because of the development of improved surgical techniques. Again, this is the overall survival rate for 142 patients, irrespective of where the bile drainage was achieved. This is cumulative patient survival. The bottom grid, the bottom plot is jaundiced, and the top is jaundice-free. It's not difficult to see that if you're jaundiced following the procedure, you do worse. This is the percent of 5-year survival with the native liver. As I mentioned, two-thirds to three-quarters of these patients will require liver transplantation, and that's pretty borne out here. This is age of Kasai in days. This is percent of 5-year survival. So here, if the Kasai is done at less than 30 days, all right, at 5 years, probably 55, 56% had their native liver. If the Kasai was done at 91 to 120 days, only 30% at 5 years had their native liver. So the earlier you do the procedure, the greater the likelihood at 5 years that you will have your native liver. Beyond that, again, obviously the number continues to decline from this very lofty level over here. As I mentioned, what's most important is the total bilirubin at 3 months post-Kasai. This is survival with the native liver on the y-axis, age in days up to 2 years, less than 2, 2 to 6, greater than 6. Easy to see that you want to be jaundice-free to have the best outcome. This was a recent study published by Jorge Becerra, a payer in clinical liver disease. Here's the diagnosis of biliary atresia. So this is bilirubin at 3 months post-Kasai, less than 2, greater than 2. Of those that were greater than 2, going on down, 82% had liver transplant. At those who had less than 2, 40% survived with a native liver. Again, the bilirubin is extremely important. Again, if you didn't have a Kasai, all these patients died. Primary transplant is very limited data, but the 5-year survival, where the primary therapy is transplant, 5-year survival is estimated to be at 75%. But again, you want the bilirubin level to be less than 2 milligrams per deciliter in order to assure maximum likelihood of survival with the native liver. Again, this is looking at it again in a different way. Why do we transfer our cases out? Again, this is an early study, but it's very telling. This is the fraction surviving without liver transplantation or with the native liver for a surgeon who does more than 5 cases a year compared to a surgeon who does less than 5 cases a year. So if you have a patient, you diagnose biliary atresia, where do you want them operated? Ask yourself. You want them operated where the surgeon doing the case does at least 5 cases a year. And again, overall survival post-Kasai, if you do greater than 5 a year or less than 5 a year. All right? Pretty obvious. So finally, if we look at the guideline for evaluation of cholestatic jaundice, I think this is from Naspigen. I sent earlier AAASLD. It says Naspigen. And this really emphasizes what I've told you earlier. Any infant noted to be jaundiced after 2 weeks, I would say after 2 days, should be evaluated for cholestasis with a measure of total and serum direct bilirubin. An elevated direct bilirubin warrants timely consideration for evaluation and referral to a pediatric gastroenterologist. Conjugated hyperbilirubinemia greater than 1 milligrams per deciliter is considered pathologic and warrants diagnostic evaluation. Direct visualization of stool pigment is a key aspect is a key aspect of a complete evaluation, and the abdominal ultrasound is useful. So it's measure the bilirubin. If it's greater than 1, visualization of stool pigment, and the abdominal ultrasound. Notice there's nothing here about laboratory studies, because the laboratory studies are not diagnostic of biliary atresia, can be associated with any one of a number of disorders. And then we talked about the fact that an experienced pathologist should look at the liver biopsy. And if that biopsy suggests biliary atresia, then key to the diagnosis is the intraoperative cholangiogram and histologic examination of the ductular remnant. That remains the gold standard for the diagnosis of biliary atresia. And that ends part 1 of this series of talks on neonatal cholestasis. And let me just